My name is Maria. I work for the Journal of Medical Device Regulation, and I will be your host today. We are thrilled that Teresa Perry from Peritus Regulatory Consulting was gracious enough to accept our invitation to share her expertise and insights with us. She has prepared a presentation for us to guide through the UKCA regulations. And if you have any spontaneous questions that arise during her presentation, then please drop them into the chat and we will answer them at the end of the presentation where there is room for a Q&A. Also, please be aware that this session will be recorded and later uploaded to our website. So should we start? We have, there are still some people missing. But if you're happy to start, Teresa, we can start with the first question.
Okay.
Okay, so thank you so much for being with us today. My first question, obviously, is please could you start by telling us a little bit about yourself and your company?
Yeah, sure, no problem. So I'm currently running Peritus Regulatory Consulting, where I specialise in quality management systems and technical documentation review and preparation. But if I look at prior to that, I spent 23 years in two organisations who are or were both notified bodies, approved bodies, certification bodies and MDSAP auditing organisations. So I've spent many years auditing and training the teams to deliver audits, as well as responding to regulator non-conformities and holding other technical roles such as certificate decision maker, scheme manager, and in operations management. So in my most recent role at GMED UK as head of the approved body, my team and I achieved designation against all three parts of the medical device regulation over a 2-year period. And in this role, I spent a lot of time working with the MHRA and Team AB to help create the guidance documents and give them MHRA feedback on potential regulatory policy. So Team AB is a little bit like Team NB, but for the UK. And so as part of that activity as well, GMED UK was the only approved body to see through an innovative device through the MHRA's pilot innovative device access pathway. So some good experience, I think, of working with the regulators. So I'll kick off this presentation by outlining MHRA's progress to their roadmap, the current state of regulation, and the new PMS statutory regulation. We'll then take a look at what the MHRA might be planning next and how that might affect the market access pathways. And then we'll finish off by looking at some of the challenges and uncertainties facing manufacturers and approved bodies as we move past the next few years. So hopefully by the end of this session, you should have a good understanding of the current UKCA status. You'll know what changes you need to build into your regulatory strategy and have a feel for and perhaps be able to plan for some of those uncertainties. Now, there is quite a lot of material here, and some of the slides are really there as a kind of a refresher, a bit of reference information. So some of the slides I might just skip through lightly and we'll focus perhaps more in depth on some of the critical changes. So I think we'll start by looking at the current regulatory environment.
Yes, great. Thank you so much, Teresa. So the MHRA has published a roadmap for implementation of its regulatory reforms. Obviously, this is a living document and may change, but can you talk us through the latest version, please?
Yeah, sure, no problem. So you can access the roadmap. You just Google it on the MHRA website. And if we kind of go back to April 2023, we had the extension of the recognition of CE marking beyond that planned Brexit deadline. And at that time, there was a lot of noise about having a full suite of new legislation, which was intended to be rolled out for 2025. Now, I think, as you all well know, there's been various regulatory and political challenges that have taken place in that gap between then and now. We've had the deadline changes in the EU. I think there's been a general lack of appetite from manufacturers for another suite of regulation. Approved body model is starting to look a little bit tenuous, I think, and we've also had a change in government. So that initial deadline is probably now not looking very realistic, and perhaps even that whole concept of a brand new sovereign regulation, the UK version of MDR, is probably not going to be the most pragmatic approach to keeping access to medical devices in the GB market. So the latest version of the MHRA roadmap issued in December last year indicated a more staged approach, with 2026 now being a target date for a more slimmed down version of the regulation. But in the meantime, we had to deal with the fact that the current legislation referred to several pieces of assimilated EU law, which were going to expire in 26th of May this year. So there was an update to the legislation to remove those expiry dates. So we're talking about legislation such as 722/2012, which is to do with medical devices utilising animal tissue, for example. Now, there was another piece of legislation issued this year which related to the critical elements of post-market surveillance, which the MHRA felt could not wait until 2026. So hence we had SI 2024 number 1368, and that had a 6-month transition period, and I'm sure you're all aware that that came into force on the 16th of June this year. So 2026 is now the kind of guideline date for the new pre-market statutory instrument. So that's when we think it's going to arrive. So we'll take a deeper dive into that in the second part of the presentation.
Okay, great, thank you. The UK is currently still recognizing the CE mark for medical devices. When is this recognition due to end?
So if you go again to the MHRA website, you'll see a nice big infographic chart which goes through all of the different devices and legislation, depending on your conformity route and whether you're MDD or EU MDR. You will have different deadlines for your recognition. Okay, so this slide is really one of those slides where it's just there. I've summarized the MHRA information, but again, always go to the MHRA website to check when your device is likely to expire. However, you've probably all seen the announcement a couple of months ago from MHRA, which said that they would be undertaking a consultation on the indefinite recognition of CE marking a little later this year. So, many pieces of legislation, non-medical pieces of legislation, have already gone this way and have taken that route. So this government is very pro-European. So I think this is a very strong possibility that we will see some of these dates removed in favour of a recognition of CE marking. And I'm guessing that's going to be under MDR or IVDR.
Okay. What are the current rules for placing a product on the GB market?
So there are a number of rules which apply to everybody. So it doesn't matter which route to market you choose, whether you've gone UKCA, CE marking. There are things that everybody has to do to place their device on the GB market. So for example, if you're a manufacturer based outside of Great Britain or the UK, you have to have a UKRP, a responsible person. So that person is responsible for registering your device, holding a copy of the technical documentation in English, and acting as that point person for vigilance, providing information such as details of importers. One key point to remember is that you can only have one UKRP for all your devices. Okay, another important point, which I think you've probably all seen various announcements about, everybody has to pretty much register their device on with the MHRA now through the DOORS system. So there used to be exceptions, and there were some devices which you had to be registered and some which didn't. Now it's pretty much everything. So that needs to be in place. Currently, under the current existing rules, if you use UKCA marking route, then you need to apply the UKCA mark to your product, and then the name and address of the UKRP on the label or packaging, or the IFU, if you're, depending on what your device is. So that name and address needs to be somewhere if you use it.
Mm-hmm.
And I think the last key area we've kind of just touched on already is the PMS statutory instrument. So everybody needs to comply with that regardless of what route to market you've chosen.
Mm-hmm. So these new post-market surveillance rules came into force a few months ago. Can you explain to us what the new requirements are and how they differ from the EU requirements?
Yeah, sure. So there's quite a lot on PMS. I think this is a good area to explore, given that it's so new. So we're going to cover all of the key requirements, but the important thing to remember is that regardless of whether you're UKCA or CE marking, if you're putting your device on the market in Great Britain, you must follow these requirements. So if we start with some of the more atypical scenarios and products, this legislation is not designed to cover clinical investigations or performance evaluations, or the exceptional use authorisations, which is where the MHRA authorise a device to be on the market if there's a desperate clinical need. So those types of devices are covered under their own reporting requirements. Custom-made devices, by their very nature, they're not likely to affect large groups of people. So again, there's a much more limited set of requirements here. So for example, you're not going to be able to do post-market surveillance reporting or PSURs because you won't have that data set. Okay, so that kind of brings us to everything else, including the CE mark devices. Now, typically, there's a very good alignment between the UK PMS regulations and the EU, but there are going to be some subtle differences, and I'll try and point those out as we go through. But one of the things that I kind of like to use as an analogy is the concept of a Class 1 device. So we all know that Class 1 devices have to have technical documentation, but we also know that this documentation doesn't get reviewed by anybody unless there's an external trigger, such as a vigilance incident. So it's going to be a similar setup with CE mark devices. The manufacturer, you have to comply with the regulation, but nobody is going to be specifically looking at those reports, for the UK PMS, unless you have a vigilance incident. And then the MHRA potentially may request to see that information. So one of the key differences to note between GB and the EU is that MHRA can ask for this sort of information to be supplied within 3 working days. So again, I wouldn't want to be in somebody's shoes if I hadn't done it, to have to kind of generate that kind of report and supply it within 3 working days. So it's important to realise that just because nobody's looking at it doesn't mean it's not a legal requirement. Okay. So the first thing that you have to do is build the PMS plan. Okay, it's the first step in the process, essentially. So this plan allows you to determine your key objectives, the methods that you're going to use, and how the outputs of that process become inputs to risk management and vice versa. Now, many of the PMS requirements are linked to the classification and therefore risk of the device. So the classification is going to determine how often key tasks should be undertaken, whether an approved body is going to be involved, and whether your methods would be considered proportionate to the risk of the device. So by that, I mean that different methodologies will be expected for a high-risk novel device compared to a low-risk, well-established technology. The device lifetime is a new sort of phrase terminology that's been introduced, and this determines the PMS period. So this is the time of manufacture to the end of the expected service life, including any shelf life. And it is important to note that if real-world data shows that actual use regularly exceeds that which the manufacturer has validated, this data shouldn't be ignored and should feed into your risk management process. So that brings us kind of nicely to real-world data. And this is data gathered from patients during the course of normal clinical care. And it is expected by MHRA that data from different groups of people is sought, including professionals and the patients themselves. And then you need to use appropriate statistical methods to kind of determine whether or not there are any reportable trends. So when we look at reporting requirements, there have been some changes here from previous UKCA legislation. So this is much more in alignment now with the EU. So we have the 2, the 10, and now the 15 calendar day reporting deadlines, which aligns nicely. So the same criteria for determining whether something is reportable is in place. That aligns as well. So that's all quite familiar to you, I hope. In terms of registering these incidents, you have to use the MORE database, and you have to apply and set up an account in MORE. And nice timing, given the date, the new data schema is now effective from today in the MORE portal. So it's a kind of an XML compatible form which enables consistent data input and analysis from MHRA. And there have been a few little changes. So they've taken away things like UDAMED references and added in things like the addition of the UKRP and UK approved body numbers, for example. Just one key point to note, it is in line with the EU as well, but just to emphasize, if there's any destructive testing that you need to do on the device as a result of a vigilance investigation, you must discuss that with the MHRA before you undertake that testing. So this is very much in alignment with Article 89 in MDR. So if somebody unfortunately has died as a result of a device incident, then there potentially is police and coroner's office involvement and could be criminal law involved. So essentially, you have to ask permission before you can destroy evidence, essentially. Okay. I think when it comes to field safety corrective actions and field safety notices, I think things are very much aligned with the EU. Perhaps some acronyms that a bit of a mouthful. FSCARF is really just the FSCA report form, so nothing too unusual there. But the MHRA do want to see any field safety notices before you distribute them. The only exception will be if it would be critical to patient safety to delay it. Okay, but otherwise you should always involve the MHRA before you distribute an FSN. So if we move on now from individual vigilance reporting, and we can now look at summary reporting. So for low-risk devices under both UK and EU regulations, there is only a need to do the post-market surveillance report. So it's a sort of a lower level requirement. Now, there is one difference. For the UK regulation, you need to prepare this every 3 years. For the EU, I think it just says as needed. Okay, but so we're talking class 1s, general IVDs, and the lower risk IVD, European, IVDR ones. So I think, again, you don't need to give this to anybody, but the MHRA, again, can ask for it, and you have to provide it within those 3 working days if requested. So that's an important point. But just because you're not registered necessarily with an approved body doesn't mean somebody's not going to be looking at this. So if you have, for instance, an ISO 13485 certification, under 721, it is a requirement to meet regulatory requirements. So your QMS auditor will almost certainly ask to see that you've produced this report at the due frequency. Okay, so moving on then to the more complex and high risk devices. As you would expect, there is more information to collate and it's more complex. You're going to have to make sure that you have GB specific data on sales, usage, incidents, etc., and kind of put them in perspective with some global comparators. So the requirement to submit to an approved body is only relevant if the device is UKCA marked. So if we look at the pink arrow at the bottom, I've given you an example here of a CE marked device. So you still have to produce the report, but there is no requirement to submit it to anybody. But as I mentioned before, MHRA can ask for this, and it would need to be supplied within 3 working days. So for the class 2A and 2B non-implantables, once you give that information to an approved body, they don't have to produce a report. It's there for their information to make sure it's being done and to give it a brief review to make sure there's nothing untoward. If a report is required, so for the higher risk, we start getting towards the implantable devices, then you will have a formal report issued, but the approved body is likely to try and align this with your technical review, so the formal reporting that they have to do anyway, rather than create an extra assessment process. Now that does have a bit of a trick, a bit of a problem. So if you take something like a 2A implantable, that device is the technical documentation is reviewed on a sampling program. So it may not be that the sampling aligns with when your PSUR is due. So that can be a little bit tricky. Every approved body is probably going to have a slightly different way of managing that, and you would need to discuss with them how they were going to approach that. But one possibility is that they may take other opportunities to look at that documentation in between your technical review sampling frequency. For example, if you have a QMS auditor coming in annually to look at your quality management system, the likelihood is they'll pick up the fact that have you done the PSUR. So it will be looked at, but the actual formal review will likely tie in with your technical sampling. PSUR reviews can also be performed by approved bodies for due cause. So if they have concerns about something and they're seeing increased vigilance reporting, or there's something, maybe they get a request from MHRA, then they can also ask for that additional review. Trend reporting is very similar to the EU. So if you haven't got an incident which is not serious and not reportable, that's one thing, but changes in the rate of incidents are reportable if they constitute an adverse trend. So you need to bear that in mind. But also, even if you've already reported that individual event, you still need to report the trend if it occurs. Obviously, custom-made devices are outside of this because you don't have enough of a data set with a custom-made device. So I think that brings us relatively up to date to where we are now.
Yes, thank you, Teresa. Wow, I have now the 3 days rule in my head. Yes. Only thinking of that. Oh my gosh. Yes, I hope everybody is prepared for this. So yeah, we're up to date, or before up to date, let's say, because there are new regulations for pre-market requirements on the horizon. What can we expect from these?
Yeah, you're absolutely right. We touched on the impending legislation release for 2026. I guess a point to notice here is that they haven't been published yet. So this point forward is, my best judgment. Things can change quite rapidly and quite substantially, so all bets are off until it's published. So as we talked about before, the MHRA publish and update their roadmap. So if we look at where we are now, the UK is obliged to provide a draft copy of healthcare legislation to the World Trade Organization 6 months prior to it being passed by UK Parliament. So if you look closely at this roadmap, you can see on that first line there that scheduled publication to the WTO was intended to be somewhere between May and July. Well, that clearly hasn't happened. So then it would be reviewed by Parliament, and typically, that was kind of scheduled for around about the end of the year, sort of December, January time, perhaps. And then you would normally have a 6-month kind of transition period, if you like, before we had to actually kind of the legislation comes into force. So that would have taken us to sort of June, July 2026. So we know the WTO submission hasn't happened. So there's clearly going to be a shift in that summer deadline, I think, for the new pre-market legislation. Now, whether any of those sort of periods of time, waiting time, can be truncated to kind of bring that back, I'm not sure. But certainly, I think the earliest you would expect it is the summer next year, and it's almost certainly going to be a bit later, I would have thought. So typically, you would get a transition period with any new legislation, and MHRA have already indicated that if you have a UKCA marked device, you are likely to have 3 years for medical device or 5 years for an IVD, or until the certificate expires. Now, for CE marked devices, we were working on those dates before, but we talked before about the fact that there's likely to be some ongoing recognition of CE marking. So I think the transition period may not be so relevant for those people. Okay. So what do we think then is likely to be in the new legislation? There are going to be some things which we can be reasonably sure about. UDI traceability, I think that's a given. There'll be some kind of unique device identification. I think the MHRA are keen to avoid duplication. So I think if you've already got a UDI system, maybe you're already registered in Europe, then I think there's going to be no need to create a brand new UDI with a new system. Your existing UDI should be perfectly acceptable. There are likely to be some up classifications similar to those we saw with the EU. So things like Class 1 reusables, 2B implantables, software as a medical device, and the IVD classification system completely changing. So I think for IVDs, the A to D classification will come in. One particular area to note is there's definitely a strong feeling that Class Bs may be self-certified, which is a complete departure from the European system. I think there's the MHRA have concerns that the Class Bs are disproportionately over-regulated. So there's likely to perhaps be some changes, but there could be some other changes. So that's one of the key things when we get the new legislation to check is where do your devices fall in terms of that classification system. So other likely inclusions, implant cards, that would almost certainly be in. We're expecting stronger requirements for documentation, but especially on the clinical side. MHRA have always been very sensitive about device claims, so I think we can expect to see something about that in the regulation. And again, a lot of alignment with EU requirements. So we can expect to see our essential requirements aligning with the GSPRs. Now, in the original consultation, MHRA were talking about the clinical evidence exemption for well-established technology not being upheld in UK legislation. So it remains to be seen whether they're going to go for that softer touch in this first set of legislation and perhaps introduce that at a later date, or whether they've completely walked away from that, or whether they're going to stick to their guns and keep that in the first set of legislation. So that would be an interesting one to keep an eye on. And I think the last area that people are quite keen to hear a little bit more about is international reliance, where you can actually place your devices on the market leveraging your existing approvals.
Yes, I would like to hear more about that because change for the UK. So how is this expected to work in practice, and what are the benefits or challenges of such a program?
Yeah, there are definitely benefits and challenges, you're right. So there are some things that we know for sure, and some that are not quite as clear-cut. There have been some regulatory and legal issues and challenges in court over the last year, which have perhaps made people a little bit more sensitive about this process. So let's take a look and see what we know, and then we can compare it with what actually happens. So the concept of international reliance is to allow medical devices that you've already put on the market in other countries with regulators that the MHRA has a good relationship with. If you've got that recognition already, then it allows you to put your device on the GB market without UKCA marking. And MHRA are very clear, one of their goals is to reduce the burden on manufacturers. If they've already jumped through lots of regulatory hoops and they have a robust approval, then let's not try and overburden manufacturers, but also to protect the patient. In Great Britain, that you want to have device continuity, and if you have a drop dead deadline where everybody's got to comply to something brand new, then people potentially will withdraw legacy devices from the market. So the comparable regulators that MHRA are currently looking at recognising are USA, Australia and Canada. So I've removed the EU from this list because essentially what I think we're looking at here is not reliance but a full-on recognition. And there will be other regulators recognised in the future. I think once this initial launch goes, Japan is certainly one that's being considered, and there may be other regulators as well. It's a bit of a challenge because a lot of regulators use a recognition or reliance program. So you can't have a recognition based on a recognition. So that's something they need to consider. It will result, I think, in a certificate being issued, but it will be a certificate of international reliance, not a UKCA certificate. And it will typically be issued by the approved bodies unless anything changes in the meantime. So there will be some factors that, again, will be common to everybody, regardless of the route that you end up choosing. And these are requirements that are already relevant to people placing their devices on the market. So the actual device needs to be within the scope of UK MDR and needs to be classified per the UK classification rules. The packaging and labelling needs to be in English. You would need to have a UKRP if you, as a manufacturer, are based outside of the UK. Same principle, registration with MHRA for the device, maintaining a UDI, and that will likely replace that UKCA mark. You would need to comply with PMS regulations, have an implant card if that's relevant to you, but also comply with other standard UK specific requirements such as units of measurement and electronic compatibility. So those items I think are all fairly straightforward. I think we are expecting some slightly more.
I'm assuming so.
Oh. We are expecting some more complex rules, I guess you could say. So again, this is a bit of information. This is the last known state of play for me in terms of MHRA communication. This may completely change. So I've already greyed out Route 2, which was a reliance route based on EU MDR or IVDR, because I think, as I said, we're probably going to see that move into Category 1 with being a complete recognition, as you would do for a Class 1 medical device. Okay, so there is likely to be very little additional requirements for those categories of products. But then at the other end of the scale, there are going to be some additional rules. Perhaps if your recognition is based on a predicate route, such as the US 510K route, maybe your classification in the UK is different to the classification in the market that you've put your device on. So there could be some particular exclusions, which will either take you straight out of the program and you won't be able to use reliance, or it may push you up into the higher category. So the higher the category you end up being in, the more aspects the approved body will look at. You'll go from one end where you might just be looking for a certificate from your regulator, like your CE certificate, to the other end where you might have to be supplying some clinical data, some predetermined change control plans for software, implant cards, PSURs, that sort of information. So it really depends on where you end up, but these rules are a little bit up in the air at the moment. And so there will be some exclusions, as I mentioned. So areas where predicate routes have been involved will come under a lot more scrutiny, and some of them may well end up being outside of the reliance route. Custom-made devices exempted, in-house devices, products that are not within the scope of the UK MDR. There will be some clear exemptions. Medicinal substances that aren't licensed in the UK, that sort of thing. So there will be some well-published and well-documented exclusions. So you would need to compare your product very carefully to see whether or not you're kind of falling into any of those groups. Okay, so I think that kind of brings us to the end of the international reliance.
Yes. Oh, did I put on my microphone? Yes, you can hear me. Okay.
Yeah.
Yes, I have maybe one last question, and then we can move to the Q&A session. Looking further ahead, what else does the MHRA envisage in terms of legislation and international cooperation? Do you have any insights on what else is on the horizon for us?
Yeah, absolutely. So the MHRA are very busy, that's for sure. So after the launch of the new legislation, they're going to be very busy redesignating approved bodies and creating a lot of guidance, because and that is ongoing now. I guess a criticism that's been levelled has been that you release the legislation and then you release the guidance, which we need to know how to do it at the same time. So I think at the moment they're spending a lot of time writing guidance for the legislation that's going to be launched next year. But I know that the MHRA are working very hard on AI and software specific requirements. I think we all recognise that this is an area of growth. So there are working parties within MHRA and within Team AB working on this. I think you may have seen information on the AI airlock. They had a project going to try and establish what the control mechanism should be for AI, because that development process is different to the regular medical devices. So I think we can expect some output, either in terms of probably initially robust guidance, and then maybe seeing that guidance move into legislation in the future as people get more certain about how AI and software should be regulated. And also, you've got that integration with the AI Act. So there's a lot of work to do there. There were other areas I think that was seen as low priority at the moment, which may end up being a higher priority. So things like products with non-medical products without a medical purpose, similar to the Annex 16 devices in the EU. So I think that's seen as a lower priority, but may pop into future legislation. And I think the big unknown is to do with clinical equivalence. So I mentioned earlier that this is an area that MHRA are very keen to work on. We might see this current batch of legislation being a slightly lighter touch than they've intended, and then being perhaps supplemented again by robust guidance, which might then find its way into legislation at a future date. Okay. So MHRA are very keen to have the UK seen as a hub of innovation. So we talked about the AI airlock, and I mentioned right at the beginning the IDAP process, which is about giving startups typically, but companies sort of that extra support, some bridging support to get innovative devices approved onto the market more quickly. I don't know if anybody's heard of Project Orbis, but that's something that's been going on for oncology products, where we're trying to accelerate patient access to new promising cancer treatments. And regulators get together, they share information, coordinate questions, and aim to kind of issue collaborative decisions to try and get those approvals happening more quickly. But overall, their goal is to reduce that duplication, help that international recognition, and just simplify market access. So I think that's the way forward. So we talked a bit about potential challenges, and one of the big challenges that can potentially stand in the way of some of those aspirations is the ability of approved bodies to be able to scale up to any demand. So there have been some significant challenges, such as a huge increase in the fees to become approved bodies, which was probably okay in the light, if we go back sort of 3 years, the big demand and the legislation that was being proposed. But currently now, with international recognition and recognition of CE marking, the likelihood of approved bodies having a huge amount of work to do, then the resources needed to maintain designation start to become a problem, and potentially that as a market access issue gives you manufacturers a lack of choice potentially in terms of approved body. So really the point of this slide is really just to reinforce the point that if you're looking at UKCA or international recognition, then you probably need to engage sooner rather than later with your approved body and think sort of carefully about that regulatory strategy to make sure you're not left out in the cold a little bit sort of later down the road. Okay.
Yeah, it's excellent advice. Thank you so much, Teresa. I think we have come to the end of your presentation, and it would be lovely if we could answer some of the questions that the attendees might have.
Right, so I think there were a few. So I had one question from Miranda there, didn't we?
Yeah.
Classification rules. So that the goal is to align as much as possible, but the likelihood is there will be some differences. So obviously the biggest difference is going to be with IVDRs, I think, as we mentioned. There will be some software differences probably, but the goal was to align as much as possible where the MHRA felt that risk was proportionate. If they feel that there is a disproportionate burden compared to the risk of the product, then you may start to see some differences. So I can't comment on the exact rule that you mentioned there, but yeah, there will probably be some differences.
Anybody else who would like to ask something? It can be specific, I think. If you have a specific device that you are looking at, or a specific rule that you are working with at the moment.
I mean, you can always reach out to me. I've put my contact details on the slides. So I presume, Maria, you'll be circulating those slides after the session. So, you can always reach out to me if you have another question.
Absolutely, yeah. So last chance, any open questions or any worries that you have? Now is your chance. Oh, that's probably not laughing for us, no? In the background. Okay. So if nobody has any questions anymore, then I think you have answered them for now. Teresa, thank you so much for your wonderful presentation. And thank you to everybody for joining us today. And I hope you can take some key takeaways with you from this session, like the 3 days rule that really stuck in my head. Thank you, everybody, and have a lovely afternoon.
Thank you for inviting me, Maria.
Of course. Thank you.
Okay, then. Bye-bye, everybody. Bye.